we'll be starting from where we left off that day, about 2 or 3 days back. And I think we left out a small part of inguinal hernia, and that is special presentations. And one of them would be a sliding hernia. And sliding hernia, although basically the hernia where the peritoneal sac is not really peritoneal sac, so the sac is only the parietal peritoneum on one side, the other side is made up of the organ along with the visceral peritoneum. So on the right side, you usually have the cecum prolapsing, and on the left side, you have the sigmoid colon, right? More common on the left side, about 80% of them are seen on the left side, and exclusively it's a male domain and more than 40 years of age. So basically here what you're looking for is you don't try to dissect out the sac as such, you dissect out the total contents from the margins of the DIR we talked about last time, both the DIRs, the superficial one and the actual DIR, and then you push everything back without ligating anything. And then you proceed as you would have done in any other case of herniorrhaphy or hernioplasty, whatever you want to do. More often it has to be plastic because the age is more than 40 years, right? The Madel's hernia, on the other hand, is basically W-shaped hernia, and the problem with this kind of a hernia is that the gangrenous loop may be lying inside the abdomen. So what you have to ensure is you have to drag everything outside, drag the whole intestine outside until you have only one afferent and one efferent from the abdomen. That is only one intestinal loop is coming out and the other is going in, right? So until you have more than one, you can't be sure whether the part lying inside the abdomen is gangrenous or not. So you have to have a single afferent and a single efferent loop or limb coming out from the DIR, right? So you have to be very, very sure about that. This happened a number of times and the patient goes back to the ward and comes back with peritonitis. The sportsman hernia is another hernia which usually is seen in athletes and heavy manual workers. And the problem with this kind of hernia is that this patient presents the typical pain in the inguinal region or in the pelvic girdle, or he may or may not be having a bulge in the inguinal region. But more often than not, what happens is that you tend to diagnose a hernia in these patients, and these patients may not actually be having hernia, or even if they are having a hernia, the remedial procedure that you carry out for the hernia, whatever you want to do, does not relieve the pain in this patient. So basically what's happening in this patient is the pain was not because of the hernia itself. It's usually a girdle pain because of the ligamentous structures and the bony structures and the muscular structures in the girdle. So you have to investigate this patient properly, and unless you negate all the other possibilities, only then go ahead and do the hernia operation, right? So MRI is the investigation of choice in these patients, and treat these patients accordingly, depending upon what this patient final diagnosis is, right? Coming to another hernia, that's a femoral hernia. This is the last part of the, or rather another of the groin hernia that we usually talk about. And this, as you know, starts from the, or exits from the femoral ring. And if you look at the femoral ring, this is basically the femoral ring, and is closed by an extraperitoneal pad of fat here. It's usually closed, and that is a condensed extraperitoneal fascia, septum out here. And the medial, you can see this lacunar ligament, so that's the medial boundary. And the anterior boundary, most anterior have the inguinal ligament, and behind that you're having the transalis fascia, the iliopelvic tract. So both of them would be forming, the immediate boundary would be the iliopelvic tract, and more anterior to it would be the inguinal ligament. Posteriorly, you see this is the part of the iliopectineal ligament. So that's basically the Cooper's ligament, which is making the posterior boundary. And the lateral boundary of this is basically a septum dividing it from the vein. So it's separating. There's a connective tissue. This is not exactly a fibrous septum as such. There's connective tissue which separates this from the femoral vein, right? So that is the femoral ring for you. And from this, the exit occurs as shown in this figure, and then it comes to the femoral canal. So this whole thing is the femoral canal. There's a femoral canal, and the lateral limb is more or less vertical. This is basically a more or less oblique or transverse, and medially, and the boundaries are more or less same, except for the fact that medially, in addition to the lacunar ligament, you'll always have the aponeurosa abdominis insertion and transalis fascia, which is lying behind this. So this whole thing is making the femoral canal. And posteriorly, you have the iliopectineal ligament and the Cooper's ligament, as was shown in the femoral ring, right? Now it extends. It's a very small path, 1.25 into 1.25 centimeters. That's the whole of the femoral sheath that you're talking about, through which the femoral hernia is going to pass through. And this is basically exiting at the ring and entering from the ring and exiting at the saphenous opening, the fascia lata. And you know the saphenous opening is about 1.5 inches below and lateral to this is pubic tubercle. So 1.5 inches below and lateral to pubic tubercle. So that's the area from which it exits. And is lying just under the fascia lata out here in this particular area, and can easily be identified because here the saphenous opening is, or the great saphenous vein is entering into the femoral vein, right? So that is where you identify it. And one more thing you have to remember out here is that the pectineus muscle is lying out here. I'll just tell you why you need to remember the pectineus muscle is lying around. So basically what lies inside this femoral sheath here out is the lymph nodes which are lying out here, or rather one single lymph node, not lymph nodes, one single lymph node out here, and then a lot of lymphatics out here, right? So that is basically the contents of the femoral sheath out here. Now this basically is a figure which tells you about the variation of the femoral hernia. So this is basically the typical femoral hernia, just lying lateral to the vein. There's the artery, the vein, the femoral vessels, just lying the medial to the vein. That's the typical femoral hernia. But you can have a more medial hernia where the lacunar ligament has fault and there's a hole in the lacunar ligament through which it comes out of, through which you have a defect, right? The defect. So that's basically lacunar ligament. And then of course there's a pectineus muscle. So this, the hernia does not exit medial to the femoral vein. Instead, it exits just under the pectineus fascia. So if you look at this figure, this would be exiting somewhere here, and the other would be exiting out here. So this is the hole in the lacunar ligament out here. So instead of exiting here, it would be exiting out here, and the other will be entering from here. But instead of exiting at the saphenous opening, it takes a path and lies under the pectineus muscle. So these are the two medial to the femoral hernia, typical femoral hernia. So you got the Logier's hernia, and this is basically a clockway hernia. So this one is to the lacunar ligament, and this is basically to the fascia overlying the pectineus muscle. And then of course you got the whole of the femoral vessels, so you can have a hernia anterior to it, posterior to it, lateral to it. Just forget about the names, you don't need to remember the name, but just remember that these are the sites. The problem with these hernias is that these are in more close vicinity to the vessels. So the chances of damaging these vessels is very real when you're trying to dissect out the sac. In this case, the problem is that it gives rise to a very early strangulation or obstruction. Both of them, right? More so with the defect in the lacunar ligament, because as it is, the femoral ring is very, very small, and now this is coming out through a defect in the lacunar ligament. So these all hernias are those hernias which would be having their own problems rather than a femoral, a typical femoral hernia, right? Now these are some of the I picked up these names, so I don't think you need to remember these names. Just forget these names. There are a lot of names, and I was going through the literature. There's, I think, about 20-25 variations of femoral hernia. I think it was the practice to name them as they wanted, right? Now, basically, femoral hernias they constitute about 3% of all hernias. More common in the females, I told you. And those, why in female? Because one, they have got a wider pelvis, so they got a larger femoral ring, right? And a wider femoral canal. Old age, low weight, buttressing fat at the opening site is reduced. So this, in old age, whether it's a female or a male, but more common in female, the incidence increases. And I said earlier, it's about 80% is in the female. So here, basically, what's happening is that there is the ligament are loose and the fat in the canal is no longer there. Now, 40% of all femoral hernias present with strangulation. The usual thing is you hardly ever see a bulge in this area unless you be very, very careful to see that particular bulge, right? So even then, you hardly ever see that bulge, right? So most of them are either, if you're fortunate enough, you can see a bulge, but more often than not, they usually present this strangulation and occult swelling or very small swelling, if you're fortunate enough to see that. And there's a very early obstruction and strangulation. This is basically the usual presentation in this patient with hernias, right? The diagnosis, as we can imagine, is difficult because hidden till quite late, and the sac as it is about only 2-4 centimeters, 2 to 4 centimeters. And the best method of diagnosing it could be a CCT abdomen for intestinal contrast. You can see the intestines exiting from the inside the pelvis, entering into the thigh in these patients, and of course a plain skygram of the abdomen to tell you about the associated acute intestinal obstruction, right? The differential diagnosis is important. Why? Because you can have a saphenous, because remember that is the area where the great saphenous vein is opening into the femoral vein at the exactly same site from where this hernia is exiting. So you can have an abnormal dilatation out there. That's number one. Number two, you can have an inguinal hernia, right? You can have a large femoral lymph node, which we all know, the lymph node of clockway. Then you can have a lipo in that particular area, an aneurysm of the femoral artery or the vein, again in that particular same area. Then you can have a psoas abscess medially placed, which can again mimic a femoral hernia, a distended psoas bursa, and of course a hematoma, the adductor longus rupture, which is lying a muscle which is lying just behind the pectineus muscle, right? Now the operations, I think you all know what the operations are all about. These are basically the RAFIs which are usually advised, and among them the femoral approach of the Lockwood is the preferred approach, right? You can have an inguinal approach, go slightly higher, and it's just like the inguinal hernia approach, same thing, except for the fact that now you have to cut through the posterior wall inguinal canal, and then you have to enter into the preperitoneal space. Until you do that, you'll not be able to dissect out the condenser sac, you'll not be able to drag the contents back into the pelvis, right? So you have to go through the posterior wall, the inguinal canal. Then you can have a supra-inguinal approach, that you're going just above, like the RAFIs, the inguinal RAFIs I told you about, where you do a plasty RAFIs, where you can go suprainguinal or plasty, the open plasty, where you do give an incision above the inguinal canal. Similarly, out here in McVitie, you have the advantage of visualization of the peritoneal cavity for bowel gangrene. So these three approaches are there. Among them, I said earlier, the femoral approach is the preferred approach, right? Plasty appears to be a better proposition, and that also laparoscopically, because laparoscopic TAPP or TEP would serve you very well when you want to cover this whole Fluchard's orifice, because remember the femoral ring is part of the Fluchard's orifice. So when you put a mesh, you have to be careful that you cover both the obturator foramen and you have to cover the femoral ring. So here also basically, in these patients, you do a laparoscopic approach. Now, one thing you remember always is that when you're doing the most commonly done inguinal RAFI, still done by, I think most about 70 to 80% of general surgeons still doing the Basini's repair. Despite the fact that we've been talking about lichen stains and talk about TAPP, TEP, but about 70 to 80% of the surgeons are still doing a Basini's repair. And the problem with Basini's repair is that you are stitching the inguinal ligament to the arching fiber. Now, when you give the stitch, the inguinal ligament is pulled slightly upwards. So when you when it's pulled slightly upwards, it actually enlarges the femoral ring, right? So if you look at the figure again, I'll just tell you, you'll be able to understand much better. So basically, arching fiber somewhere here, and this is the inguinal ligament, right? Now you're stitching somewhere here. So when you're stitching this parallel, you are basically enlarging the ring. When the ring enlarges, the incidence of femoral hernia increases. And that is a documented fact that one of the common causes of femoral hernia could be a previously done inguinal hernia, RAFI, especially the Basini's, right? So that has to be remembered. The emergency when you got obstructive strangulated hernia, you're doing a Lockwood's approach and you want to push everything inside, you're not able to do so. So obviously you'll have to enlarge the opening, and your immediate impulse would be, medially there's no problem, let me cut the lacunar. Laterally there has to be a problem. You got the femoral vein there, so you can't dilate the opening laterally. You have to do it medially. But when you're doing it medially, this is the part. So you have to cut somewhere here. Now remember one thing. See this aberrant obturator in close vicinity out here. So basically an aberrant vessel could be running along the axis or it could be running across the lacunar ligament. The moment you cut it medially, this is the way you have to cut it. So the moment you cut it medially, you're going to damage this vessel, whichever vessel is there, and that is going to lead to very troublesome bleeding. And you have, even in certain cases, because if that forms the major vessel and the aberrant forms the major vessel instead of the major obturator artery, you have had it. So never do that. Never do that. You can dilate it, but never cut out here. So what else can be done? Why not cut here? Why not cut here? So you can divide the inguinal ligament instead of dividing the lacunar ligament, right? So basically, and this is basically the open operation when you're going from this approach. You're entering from here, you can't see what's lying inside. You can't see from here where there's a vessel lying deep to the lacunar ligament. So in that case, you can't cut, right? But suppose you're doing a TAPP or TEP. You're entering from where? From inside. You have the whole lacunar ligament in front of you. If there's an abnormal vessel, you can see that abnormal vessel. So division of the lacunar ligament is fraught with danger when you're doing an open approach, the Lockwood approach, and it can easily be done when you're doing a TEP or a TAPP or a endoscopic approach, right? So if at all you want to enlarge the opening, what you can do is you can cut the inguinal ligament. So cut the inguinal ligament rather than cutting the lacunar ligament. So one is the aberrant obturator vessel, which is going to be damaged. The second thing is the lacunar ligament is so small only 0.5 to 1 centimeter. That even if you transect it, may not enlarge the opening enough for the intestines to be deposited back into the abdomen, right? So laparoscopically, you cut the lateral ligament under vision. You can see this vessel there or not. Now coming to other very interesting hernia, the supravesical hernias, and these are hernias which hitherto had not been recognized at all. I think even the last 5 years, now people know about what supravesical hernia is all about. So basically here what we're talking about is the supravesical fossa. And from the knowledge that we already talked about, we all know supravesical fossa is lying in between the two medial umbilical ligaments. And in between you got the median umbilical ligament, right? So in between you got the medial umbilical ligament, and here you got the two laterally placed medial umbilical ligaments. So this is N ligament, these are the L ligaments. So in between you got the supravesical fossas, and the two combine to make one large supravesical fossa. So that is basically the lateral boundary. So the lateral boundary supravesical fossa would be what? The two L ligaments, that is medial ligaments, right? So medial ligaments. Now, the inferior boundary is by the peritoneal reflection of the bladder. That forms the inferior boundary. So there has to be a weakness in this particular area. Whenever weakness in this particular area, the sac can either protrude externally or it can protrude internally through the supravesical or the rectovesical fascia or supravesical fascia. Now, basically, when talking about the fascia, the peritoneum has got a transverse fascia in front of it, right? Now, what is this fascia going to do? This is the rectovesical fascia we're talking about. That is the third layer or the condensed fascia over the bladder. So when it bursts through this bladder, I have a figure. I'm sorry, I don't have a figure to make you understand this better. So when it goes through this particular fascia, it can either exit externally, can be seen in the abdominal wall, or it can exit posteriorly around the bladder. And that is why it is either anterior supravesical. So this is the inferior, the internal type, anterior supravesical, right or left lateral supravesical, and posterior supravesical. That means around the bladder it can have hernia on all sides if it were internal supravesical. But then that is a hernia which can only be diagnosed on a very proficient CT reader, or you can diagnose it only when you're doing a exploration. But by and large, the external supravesical hernia is the hernia that we don't understand. Why? Because even when you're doing an open operation, we diagnose it as a direct sac. Why? Because not very careful from where it is coming from. You just dissect it from the margins and shove everything back in without bothering from where was the neck coming from, right? So basically, this would be more medially lying neck. See this figure. See this figure. This is the median, the N ligament. This is the L ligament, and this is the lateral ligament, right? So this is the MN, ML, and lateral ligament. See, this is exiting from where? In between these two. This is the supravesical area, right? If you had a direct hernia, it would be exiting somewhere here. The indirect exits here. The direct hernia, this is the area of the posterior inguinal wall. That is the area from it would exiting. This is lateral to it. That's the deep inguinal ring, right? So any hernia between the ML and the MN. So this is the ML and MN ligaments would be an extra supravesical hernia. But the problem is again one more. And the problem is that the ML ligament, this is a rigid ligament. That is, it has got a lot of fibrous tissue in it. So when this tries to burst this particular area, more often than not, it's not able to do so. So one, it could be coming out from this area. When it's not able to come out through this particular area, the sac can always come out through this particular area. So here is it presenting as what? The direct inguinal hernia. So either it comes through the anterior wall, or it can come through the medial end of the Hasselbalch's triangle. So this is the Hasselbalch's triangle we're talking about behind this. So it is coming out from here. The third thing is it can go deep down and come through the femoral opening, or deeper down it can come out through the obturator canal. So remember, the supravesical, the external supravesical hernia could be coming out, number one, through the anterior wall. In that case, it would be lying medial to the pubic tubercle. Because remember, here is the pubic tubercle. Here's the pubic tubercle. So medial to it would be the extra supravesical. Lateral to pubic tubercle would be the direct, and more lateral to it, lateral to the inferior epigastric vessel would be the indirect inguinal hernias, right? So this is always misdiagnosed clinically as a DIH, and that is the three-finger test I was telling you about last time we were talking about the investigations done. And the three-finger test, just remember one thing, and that is if you're doing a three-finger test, in that case, remember, if all the fingers in place, if you still have a bulge, medial to the pubic tubercle, it has to be a supravesical hernia. If you don't have a bulge, then you don't have a supravesical hernia. So that is the modified three-finger test that you have to understand these patients, right? The symptoms are again the presentation, usually as a diagonal hernia or a femoral, very rarely, or even much more rarely as an obturator, more commonly as a diagonal hernia. And the usual complication in intestinal obstruction, not very common. Why? Because the whole of the base is so large that usually strangulation doesn't occur, but you can have intestinal obstruction as it is. A CT scan may help you. A CT can help you. And the treatment, of course, is open or a laparoscopic. Laparoscopic would be the final diagnosis. It tells you from where it is entering. You can see that you identify the ML ligament and you find this hernia or the gap medial to it, right? Although clinically you may have diagnosed a diagonal hernia, but you see the gap from there. So you can identify, look, I'm looking at a supravesical hernia. Now coming to the most important part, and that is the ventral hernia. Now what a ventral hernia is all about? Now ventral hernias basically are defined all hernias from the anteabdominal wall, excluding the groin hernia. So you don't include the groin hernias in this. You exclude the groin hernias, and once you exclude that, the rest of the hernias are considered to be the ventral hernia. So top to bottom, right from epigastrium down to the pubic bone, and laterally up to the spine. So all of them would be considered as ventral hernia, right? First of all, the spigelian hernia. This is one which is not very uncommon. I would say you do find patients with spigelian hernia. And basically, if you look at the spigelian hernia, you have to understand what the semilunar line or the spigelian line is all about. Now, spigelian line basically is a bilateral vertical curved line in the anterior abdominal wall, right? We talked about that when we were talking about the abdominal wall in the first lecture, right? Before this. So where the layers, no, where is this line? This is basically a line where the rectus sheath has fused lateral to the rectus abdominis muscle and medial to the oblique muscle, right? So if you look at this figure, see this figure? So these are basically the muscle fusing out here and there. So here you have the semilunar line or the spigelian line. This is basically the line we're talking about, right? The line out here. Now, when you talk about this line, basically it extends from where? The ninth rib to the pubic tubercle. You can see this very well out here. Ninth rib to the pubic tubercle. We are not worried about the whole line. Why? Because the weakness of this line in this particular area, which you have identified as the spilesian zone. And this zone is 90% home to 90% of spigelian hernias. And this zone basically, you talk about a transspinal line across both the ASIS, and you take 6 centimeters cranial width. So when you take the 6 centimeters cranial to the interspinous line, this whole area is what is known as the spigelian fascia or the spigelian zone, and the area which is most susceptible. And here you will find the intersection between the spigelian line and the arcuate ligament or the arcuate line. Arcuate line, you all know, is the semilunar line, which is the lowermost extent of the posterior rectus sheath, right? So basically that is somewhere here. So this whole area is at increased susceptibility to genesis of a spigelian hernia, right? Now, look at the clinical presentations. One, this is the internal oblique, the transabdominis, and this is the external oblique aponeurosa. Now, basically, above the arcuate line and below the arcuate line, it differs for the simple reason that below the arcuate line, the three are fused. Above the arcuate line, the internal oblique, it divides into two, combines the upper lip combines with the external oblique, the lower combines with the transabdominal. So when you have above the arcuate line, you basically have the sac entering from here, that means through the transabdominis gap. Either it can present in between the transabdominis and the internal oblique muscle. That is one place. You can have the sac here. Cannot be diagnosed clinically. Or if you find there's a weakness in the internal oblique, now the sac presents between the internal oblique and the external oblique. Now this we all know is a area which can easily be dissected out. Remember when we talk about the anterior CST? When we talk about anterior CST, we said they can easily enter into the plane between the internal oblique and the external oblique. So you can easily enter this plane, and this sac mushrooms. See, this is mushrooming out here. That is what is happening in this patient. So that is the most usual presentation, and the sac is lying between the internal oblique and the external oblique. Internal oblique, external oblique. and usually may not present as a skin bulge. But if it is perforating or penetrating to the external oblique aponeurosis, then it will present as a bulge. Or it has weakened the external oblique aponeurosis so much that the whole thing is bulging, then you have this bulge like this, right? So either perforating or weakening the external oblique aponeurosis to such an extent that the external oblique aponeurosis now starts bulging. So in both the conditions, you have a skin bulge. The other place where you can present it with it at the area underneath the rectus abdominis. That means in between the sheath and the rectus abdominis. So these are the places where the spigelian hernia can present, right? So these are the presentations. Usually presents as pain without an obvious swelling, or you can see a bulge. But more commonly, you have the complications, which are more common presentations, right? And these complications most commonly are the incarceration and the obstruction and the gangrene. The diagnosis, as you may well imagine, is usually done by either HRS or by a CT scan. And laparoscopy should be the choice. Why? It is both diagnostic and therapeutic. Or if you have been able to diagnose or pinpoint the particular defect, you can even go in for an open approach to this patient. What are the umbilical hernia? As far as umbilical hernia is concerned, just a few words about exomphalos, because this is basically an area which is at the same particular area. In exomphalos, you have the two layers of thick covering, the amniotic membrane outside and the peritoneum inside, right? The incidence is not very uncommon, 1 in 5,000 and 1 in 10,000, the giant and the smaller ones, because initially we had the differentiation as a minor and a major. The minor we were taught were less than 4 centimeters, and the major was more than 4 centimeters diameter of the sac, and it used to include the solid organs like liver, spleen, and the cord were attached to the lower surface of the mass as distinct to the minor, where the cord was usually attached to the most prominent part of the sac, and it had only bowel in it. This was I think the old. They no longer have the minor and the major. We now only have two. One is the giant. Basically the giant exomphalos, and the giant exomphalos are basically defined as those where there is a loss of abdominal domain. And loss of abdominal domain, we're repeatedly talking about that. I think even in the past and even future talking about that. That is basically the sac volume is more than 25% of the whole abdominal volume. That is the loss of abdominal domain. Some people may call it 30%, but 25% is a safe level. That is the usual definition of abdominal domain, right? And usually this mass does not have any skin covering, or may have just partial skin covering at the base. What is more important is almost 70% of these are associated with other congenital abnormalities, and you have to look for them. And these are usually syndromes which have almost 4 or 5 other abnormalities, like for example, the Beckwith, Weidenman, and the Cantrell's pentology. Pentology basically means the other 5 problems in this patient, or 5 congenital abnormalities. But cardiac abnormalities are not very uncommon. 20-40% of them will be having a cardiac abnormality. And associated chromosomal abnormality is there. But it's more common in premature infants and patients or in infants who have been subjected to IUGR. The management, the problems is number one, the danger of rupture is always there. You don't want the sac to rupture, otherwise you have everything in your hands. The loss of fluid is there through the sac. The loss of temperature is there. The chance of infection is there. And main thing is in those which the volume is slightly more, the disproportion between the volume of the sac and abdominal volume may result in abdominal compartment syndrome, right? Conservatively, you have the antibiotic, the temperature control, fluid control with gauzes, and if you soak the gauze in wet saline, the problem is there would be further heat loss. The water evaporates and takes the heat along with it. So wet gauzes are not to be put in. Instead, the gauze has to be covered with dressing material that is either betadine and or silver sulfatizing. The problem with both is that we apply too much of it. Betadine leads to thyroid toxicity, and silver sulfatizing leads to leukopenia, among others, right? Apart from the silver toxicity. So you have to keep changing between these two. So once you use betadine, few days you use SSD. Initially, they used to use a very good desiccating solution, which was mercury solution. It gave very good results, very good results. Immediately, within 2 to 3 days, there was a scab formation. But the problem with mercury was that it led to increases as a kidney toxicity. So it's been discontinued. Nobody uses it anymore. So what are you waiting for? You basically wait for the gradual reduction in the size of the sac. And once it happens, then further treatment can be carried out as like for a ventral hernia, right? Operative, if it's a small size, you're very fortunate, the child is very fortunate, the infant is very fortunate, you could do a primary repair. But more often than not, you're not able to do it. Even the second option could be just mobilize the skin and close the skin over that defect and treat this as a ventral hernia. That is again a very favorable outcome, but even that is not usually possible, despite the fact that you may give a relaxing incision in the back. If you give a relaxing in the back, you can easily close it in the front. But despite all this, it leads a lot. It leads to what? A lot of bleeding, a lot of blood loss. And in an infant, blood loss could be critical and crucial. So you don't have to, you can't usually do these things, right? If the large size, basically what you do is you have to stage repair with either a mesh or skin. Most common is what we do is that you usually cover the whole thing with meshes all around, right? Stitched to the skin margin at the edges of the umbilicus or the would-be umbilicus, and on top it closes like a tent, and every time within 1 week or 2 weeks you further decrease the tent size. So you just give a further suture out here, then give out here, then give out here. So ultimately it looks like something like this, and the whole thing is gradually deposited back. So this is basically gradual reduction of the contents into the abdominal cavity. So that usually gives time for the diaphragm to move up, the walls of the abdomen to enlarge and start accommodating what was always lying outside the abdomen, which is now being pushed into the abdomen. So that is a gradual reposition of the contents. And once you've done that, then you go ahead and do a stage repair, whatever you want to do. Now coming to the umbilical hernia. So congenital umbilical hernia is not an entity. It's always acquired. If you have a true skin covering in a patient who's born with umbilical hernia. So when you have a patient born, you usually will find that these patients don't have umbilical hernia. It develops within a couple of days. So if you have a true skin covering, it has been an intrauterine epithelialization, right? But otherwise, it's usually an acquired condition, and usually this acquired condition, because of what? It is secondary to umbilical sepsis, ascites. In adults, that is the usual cause. Umbilical sepsis is the most common cause, right? That is responsible even for development later on in life. The thing that you find in these cases is the absent vesico-umbilical fascia, also known as the rickets fascia. Usually seen either sex, it doesn't have any sexual predilection, and more common in blacks. But complication is extremely uncommon in these children before 3 years, because the sac is so the neck of the sac is so wide that complication never occurs. And the parents should be basically they should be told that don't be concerned, because the concern is very much there. You find all these patients, every time you find these patients, the parents coming with the child that, look, this is the very last one, what should I do about it? Then basically what you have to do is you have to advise these patients to wait and watch. Why? Because self-resolution occurs in 95% of these children. And especially if the sac neck is less than 2 centimeters, 95% of them would be resolving. So don't really require any surgery in these patients, right? Even if it doesn't, in 5% of these children, then go ahead and do a TAFE. So remember one thing, that in these patients, be careful advising surgery before 2 to 3 years. Okay. Now, paraumbilical hernia. One thing which is very important is, what is a paraumbilical hernia? Now, umbilical hernia, as it is very, very rare in adults. Remember this. This is a very important statement. It's rare in adults. It's usually a paraumbilical hernia. And it is a hernia which is usually adjacent to the umbilical ring. And that's the usual type of hernia around the umbilicus in adults, right? The umbilical ring is incomplete. So if you look at this patient, the ring would be incomplete and it would be seen as a crescent-shaped ring. It is not a complete ring. It is a partial ring. A crescent shape is basically. So somebody's got the mic on. Kindly close the mic. Okay, thank you. So basically, it's got a narrow neck. So crescent shape I was talking about, the moon shaped umbilicus out here. So basically, what you're finding is you don't find a complete neck, umbilical ring like this. It would be crescent shaped, and the part which is not seen is the bulge. So you'll find the bulge in the rest of the ring, and the other part of the ring would be seen as crescent shape, right? So it's got a narrow neck, and the contents obviously could be the bowel and the omentum. The precipitating factors in these patients is most commonly pregnancies. most common cause of pregnancy. So you find this very commonly in females. That's why you find the ratio of female to male almost 5:1. And the precipitating factor apart from pregnancy is obesity, right? So abdominal pain, especially postprandial, usually because of traction of the stomach or transverse colon, may be presenting with vomitings, not a very common presenting complaint. Again, treatment, remember any ventral hernia, this figure was initial 1 to 2 centimeters, now it has come down to 1 centimeter. So any hernia less than 1 centimeter should be subjected to a plasty. Any hernia more than 1 centimeter should be plasty. Any hernia less than 1 centimeter has to be could be a Mayo's repair. But when you're doing a Mayo's repair, remember a double breasting. But the double breasting should be such that the overlap between the two edges should be at least 5 to 7.5 millimeters. That means it should be somewhere in the region of half to 1 centimeter. If you don't have that much overlap, your Mayo's repair is bound to fail. If it's more than 2 centimeter defect, then of course it has to be a plasty. Either do an open plasty or you do a laparoscopic plasty, right? Now, okay. Now, epigastric hernia. What's an epigastric hernia? Usually any midline defect, bulge or more by palpation, anything in between the umbilicus and the xiphisternum. And the usual content is the preparatal fat. Usually, most commonly, these have a small bulge or they don't have any bulge, right? And usually seen in heavy manual workers in the age of 30 to 45 years. Usually asymptomatic. The symptom of epigastric pain should exclude other commoner causes. If the patient comes to say, look, I've got this swelling and I have pain in the abdomen, don't look for this as a cause or don't suppose that this is the cause for abdominal pain. If the patient has got epigastric pain, be sure of one thing, that probably 99% of the time, this epigastric hernia is not the cause for the epigastric pain. So look for the cause. What is the cause of epigastric pain? You have to look for that. So that's why it's usually asymptomatic as such. So you have to look for the cause. Treatment again is less than 1 centimeter, more than 1 centimeter. I already repeated. I told you that. The recurrence rate is very important. And why? I'll tell you why. The reason is that in the OPD you saw this patient and you had this bulge, very small bulge, and the patient probably wanted or didn't want. You persuaded him that look, you got this kind of a hernia and you should get it operated. In his wisdom, the patient consented that yes, look, we can operate on it. The spinal was given or GA was given, and then you start searching. One, the abdominal whole thing is collapsed. Now you start searching for that opening. And more often than not, you will never find this opening. And what happens? You start dissecting at random places and you say, I've done a very good repair. And subsequently what happens? The patient gets up and before he gets discharged, he says, look, I've got the swelling again. So what happens? What is happening is often the swelling, the opening is so small, the surgery should not have been done. But because you chose to do it, you could not identify the opening once the patient was lying in the lying posture and the abdominal wall was fully relaxed. So remember one thing, if at all you want to operate in a very small hernia of this size, always mark the site with the patient standing up. Never forget this, for God's sake, don't forget this. Always mark the site. If at all you want to operate, don't operate in very small hernia, don't do it. But if at all the patient wants to do it, wants to get it done, or you want to do it, you can at least mark the site before the patient lies down, and then you're in a safe domain. You can easily identify, look, this is the area the opening was, and I'll just go and dissect it out, right? So never forget that. And that brings us to, so that is a non-identification with a small site. That is the main important. The other is that in these patients, you could be having a small defect like a Swiss cheese defect, another defect. And we're doing an open surgery. You can't see the defect unless until you're giving an incision right from the xiphisternum to the umbilicus. Now, is it worth it in a patient very small epigastric hernia to give such a large incision from the epigastrium to the umbilicus? I think it's criminal. It's criminal. So don't do it. Don't do it. If at all possible, go ahead and do a laparoscopic, at least a laparoscopy, even if you don't want to do a laparoscopic repair, at least do a laparoscopy. Or if at all, get a CT done in this patient to see for any other non-obvious defects which are there, but these are not very obvious clinically, right? Now, the second thing is a very, very important thing. Often in the OPDs, the residents ask you, which is epigastric and which is paraumbilical. When do we call a hernia in between the xiphisternum and the umbilicus as a paraumbilical, and when do I call it epigastric hernia? Now, there are a number of definitions. Nobody agrees on that, but a logical definition would be that anything in close vicinity to the umbilicus. Now, what I was saying close vicinity is any hernia which is distorting either the total or the part. That means the crescent shape. If you find the crescent shape in any hernia, that is a paraumbilical hernia. That's one part of the definition. The rest of them should be known as epigastric. The other part of the definition is that any hernia which is beyond 3 centimeters from the umbilicus. That means you take 3 centimeters from the umbilicus, and beyond those 3 centimeters up to the epigastrium should be known as the epigastric hernia. Once you come to the domain of 3 centimeters around the umbilicus, it should be paraumbilical hernia, whether it's cranial, caudal, or lateral, whatever, right? So these are basically paraumbilical. So the two parts of the definition, stick to whichever you want to, but you should know both these definitions. Okay. Now coming to the most important part, and that is the incisional hernia. What's all about? So we'll be sticking to recommendations of 2019. Look, when we were about 2 years back, it was only recommendation 2015 and 17. Now, recently, last year, these recommendations come in and everybody agrees with it. So we got two parts of recommendations, part A and part B. If you want, you can go ahead and look it up in the literature, and these are easily available. The IEHS recommendation, hernia, part A and part B. Just note it down. If you want to look at the full recommendations, it's very tedious. We'll stick to what is required by us. One thing we need to remember is that is ventral hernia and incisional hernia different? Yes, they are different. And the problems of ventral hernias should be treated separately, because incisional hernia is also a midline defect. You give in a basically umbilicus, a midline, you've done a midline surgery or a paramedian surgery. In both instances, the hernias will be in the ventral wall, right? So they should be treated as ventral hernia. But no, the ventral hernia and the incisional hernia are absolutely two distinct entities. And the recurrent ventral hernia should be tagged onto the incisional hernia. So you got two entities, one ventral hernia, primary, and number two incisional hernia plus recurrent ventral hernias, right? So this is basically a recommendation of that, recommended to talking about 90. And it stands to reason, because the problems in both the conditions would be entirely different, right? Now, the incidence is quite high, 2 to 10% or more of all laparotomies will result in incisional hernia. Now, probably this figure is probably higher, and the literature figures of as much as 20-30% has been given. I don't know how much to believe those, but yes, the figure is which all agree with is 2-10%, right? And as far as laparoscopy is concerned, port site figures from port site hernias 1 to 5% of all laparoscopy or laparoscopic operations being done, especially from, they never do it from the 5 millimeter. They never exit from 5 millimeter. So 5 millimeter ports never ever give rise to port hernias, but anything 10 millimeter or more will give rise to port site hernia, right? So the most common complication after laparotomy, see how common it is, 2 times more common than adhesive bowel obstruction, and most common indication for reoperation of laparotomy, that means real laparotomy, and how much? 3 times as compared to reoperation for adhesive bowel obstruction. So the only thing competing with the commonness and the commonness of reoperation, commonness of the existence, is adhesive bowel obstruction. And incisional hernia is 2 times more common as far as the complication is concerned, and 3 times more common as far as the need for reoperation is concerned as compared to adhesive bowel obstruction. Now, bigger the incision, the higher the risk, right? Median hernias, we are talking about 70% are median hernias, 17% are lateral hernias, and 6% are iliacal. These are all basically incisional hernia we're talking about, right? If you look at the causes, the patient factor, the wound factor, the surgeon factor, and technical factors, and these are the factors that I remembered. The factor which influences incisional hernia formation is basically, remember one thing, this is very interesting. Now, what is said is that most of the incisional hernia, whether they are manifesting immediately after surgery or they are manifesting, let's say, 1 year after, 2 years after, 3 years after, 4 years after, no matter what, most of them would be the dehiscence, either partial or total, in the early postoperative. That means the seed of the incisional hernia most often is sown right in the immediate postoperative period. It's another matter whether it manifests immediately or it manifests late in the life of the patient, right? But the problem is that in most of these patients, the reason for incisional hernia, the cause of dehiscence, is right at the time in the immediate postoperative period. That means most of them are technical factors, right? Late incisional hernia, let's say about 4 years, 5 years, 10 years later, it is the patient factors which predominate. And the detection rate of the incisional hernia, that substantiates what we are saying above. That substantiates the belief that initial is technical and patient. Why? Because look at 1 year, almost 50% incisional hernias are manifested within 1 year. And the rest 50% would be manifesting late over the lifetime of the patient. 25% in 2 years. The rest 15% 3 years. Right? So the gradual time passes on. Then the chance of having technical factors as the prime, they decrease, they start receding, as probably what is working in these patients is some other patient cause, right? If you look at the patient factors, apart from the fact that the age is there, the obesity and BMI 30, more than 30 is probably one of the most very common factor, most important factor. Then if the bowel or the abdomen has been subjected to multiple operations, like example, a number of seizures, 2, 3, 4 seizures. You see patients all the time with 3 or 4 seizures down the infraumbilical area, right? Those scars are there. Then post-operative chest infection, colostomy sites. You have closed the colostomy, you just close it. It is bound to give rise to a hernia at the site where you close the colostomy, right? A persistent peritonitis, either a secondary or a tertiary peritonitis. We all know what tertiary peritonitis is all about. I'm not going to go into the details of that. If a patient has got visceral cancer or ascites, then general factors, anemia, hyperproteinemia, smokers, chronic obstructive lung disease, diabetes, failure, constipation, again a very important factor, prolonged use of steroids, heavy manual work. So basically all causes which are either weakening the wall or causes which are leading to a decrease in the healing capacity or generalized decrease in the fibrotic capacity of the abdominal wall, right? Right. The wound factors are again important. If you look at the wound factor, these are those factors which are usually there in the early period. So you have a CDC, SSI, CDC 2 or 3. Even that's there because stage 1 or CDC 1 is basically just a superficial skin infection that doesn't give rise to any kind of cell hernia. But the moment you have a deeper infection, right, deeper infection, whether it is a deeper layer, that means the underlying layers, or you got a middle layers, whatever, right? So in these cases, incisional hernias are more common, right? Defects in wound healing, because we all know that when you talk about the abdominal wound, if we talk about surgical site infection, the most common is basically the skin involvement. The second is basically involved in the muscular layer or the tissue layer. And the third is basically involvement of the total layers or just the underlying layer. And that is basically what defects in wound healing, defects in extracellular matrix synthesis at work. When we talk about inguinal hernia, the same factors are working here also. Emergency surgeries. Emergency surgeries give rise to the most, as compared to elective surgeries, the incidence of incisional hernia is more common in emergency surgeries. Any cause for raised intra-abdominal pressure, like for example, damage control surgery, a burst abdomen, a prolonged ileus. You have done some kind of surgery and you find that the ileus persists for 2 days, 3 days, 4 days, 5 days, even for a week. There are instances in old age, the ileus will persist for as much as a week or 10 days. These patients, be sure, will always have incisional hernia. And the underlying term, always, 100%, they would be having incisional hernia later on. Why? Because tension is so much, especially with the old age, with the prolonged ileus, they usually have incisional hernia. Recurrent vomiting in the immediate period. You're given, so that there the choice of anesthesia makes a major role. You're given some kind of general anesthesia, and the patient keeps on puking throughout in the post-operative period. And every time with each contraction of abdominal wall, the tension is occurring at which side? At the site where you have stitched everything up, right? The technical surgeon factors, I think we talked about these factors. We talked about the closure of the abdominal wound and we talked about the abdominal wall muscles. Just to remind you of those, midline incisions, especially infraumbilical. Remember, we all know that infraumbilical midline incisions, because there is no posterior rectus wall, rectus sheath wall, that creates a problem. Wrong suture material. Remember, I told you the best suture is what? The PDS. So remember, if at all possible, always use a PDS suture or polydiaxanone suture. That should be the suture of choice. Even a 2-0 would work very well with smaller needle. I told you. Remember last time I told you, the larger the needle, the more the cut through at the bite side, and every bite with a large needle, especially cutting large needle, would create an opening, and which would lead to what? The needle hernia, needle side hernia, right? Give rise to the Swiss cheese appearance. Then wrong suture length. We already talked about that. It should always be more than 4:1. Wrong bites. It should be less than 1 centimeter and less than 1 centimeter interval. Wrong pattern of stitching. Too tight. Never be too tight. I've seen residents doing it tight, tight, and tight. Why? They want to have very good opposition. Don't do it. Not only residents, even surgeons do it. So don't do that. Don't do that. The more tight you do it, the more necrosis is going to occur. The most the post-operative necrosis, the more the chances of the incisional hernias, right? Tension at the stitch line. You try to drag everything into place. The tension is there. The stitches become too tight. So everything works against the patient in favor of a later on development of incisional hernia. And never drain through the main incision line. Never do it. If at all you want to drain the main wound, always put in the drain through a separate incision. Right? So never do it. Okay. So what are the presentations? Most common single, very well, no problems. But remember, even when you're doing a incisional hernia, always be careful to see whether there's an other defect or not. More often than not, you will have a other defect either below or behind or whatever. So remember one thing, in most of these cases, always look for multiple defects. One was Swiss cheese defect. Always starts early post-op period. We all talked about that, right? Sinoconon, what is basically the typical presentation? You remove the dressing the second, third day, which you should in any surgery. Normally 48 hours, 72 hours online, the first dressing change should be done. Okay, when you do it, you just find a small amount of serous sanguineous discharge. You're very happy. Look, there's no infection. I just had a small amount of serous discharge. Don't be so happy. Don't be so happy. That serous sanguineous discharge from the incision line tells you only one thing, and that is there has been an underlying disruption. There has been an underlying disruption. And that underlying disruption is going to give rise to a future generation of incision hernia. So, the serous sanguineous discharge is basically a harbinger of underlying disruption. And that is again very important, one other aspect. And that is, in this patient, for God's sake, do not remove the skin incision at the time of discharge. Never ever do it. If the patient has serous sanguineous discharge, never ever remove the skin incision. What's going to happen? You remove the skin stitches, you discharge the patient, and 2-3 hours later, the patient comes back to you, the balls hanging out of the abdomen. What has happened? The deeper layers were already disrupted. The skin was stitched, you remove the skin sutures. Is the skin get enough, the scar has enough tensile strength within 1 week? I told you, never. Never. Takes about 4 to 5 weeks for 70%. Even then, it doesn't have a full thing. 4 weeks for the 70% strength. So what is happening out here is the slightest amount of pressure over the scar disrupts the skin also. Then now the patient has a burst abdomen. So remember one thing, the patient has serous sanguineous discharge, never remove the skin stitches immediately. Never do it, right? Within 7 days. Never do it, leave them. But at least you are doing one thing. You are converting the whole thing into a ventral hernia. At least you are giving the benefit to this patient, because managing a burst abdomen is an entirely different proposition. The common manifestation is basically what? Non-specific abdominal pain, a painless bulge, maybe single or multiple bulges, increases with time, skin is stretched, and may even be thinning out to the extent that the patient will be having ulcers over it. These are basically what? Ischemic ulcers, right? Irreducible is more common than reducibility, because by the time the patient has come to you, these are mostly irreducible. And the patient can be presenting with obstruction for the first time or strangulation for the first time, right? Clinical examination should be more than enough, but remember one thing, and that is it should not be enough for proceeding with surgery. Why? Because you have to diagnose what? Number one, a Swiss cheese defects in these patients. So do a CT examination. In other words, else, one more thing, in those patients who are very, very obese, a diagnosis of incisional hernia is very, very difficult. You may be feeling that there is something out there, but the problem is that you're not able to feel the bulge. So a diagnosis of a hernia in a very fat abdomen. Number two, diagnosis of Swiss cheese defects. Number three, the contents of a sac volume, adhesions, and mapping of the defect site. Why is sac volume important? Sac volume is important. Why? Because again, we are talking about the abdominal domain. If you have a loss of abdominal domain, basically meaning if the sac volume is more than 25%, then there is a different proposition management. If it is less, there are different options for management, right? And mapping of the size, the defect size is very, very important. These patients, adhesions again is important, and that brings us to a very important thing. Why the size is important? Because you should always do a size measurement and classifying according to the EHS classification for incisional hernia. Always do it. Always do it. It gives you a wide range of options available, right? So basically talking about a primary or a recurrent. Okay. Now, apart from that, midline. And how do you define the midline? Just really what the midline is. Basically, midline labeled as M1 to M5. lateral L1 to L4. And then recurrent yes or no, basically P or R. And then of course the length, whatever the length is, mentioned in centimeters, but that's not very important. It is important, but not very important. But the width is more important. And width W1, W2, and W3. So less than 4 centimeters, 4 to less than 10, 10 or more than 10. The W3, right? Now, first of all, let's talk about midline. What does midline constitute? Midline or medial hernia basically constitute what? They basically constitute laterally. See, the lateral margin of the rectus sheath. So basically, any hernia lying between the two rectal sheath margins is a medial, right? And medial hernia basically has got one advantage to it, and that is it has got a buttress of the rectus abdominis muscle. If it has not undergone atrophy, if you were not careful enough, it would have gone atrophy. Why? Remember the earlier class I told you, excessive mobilization of the rectus abdominis. You touched upon the posterolateral supplying vessels of the rectus abdominis. You have damaged those vessels, so this patient has got an atrophy of the rectus muscle. So the medial defect does not, having medial lateral doesn't make much of a difference. But remember, in those where the medial defects, they have got the buttress of the rectus abdominis. Anyway, so basically, so the two lateral rectus sheath above the xiphoid and below the pubic bone, right, or the upper margin of the pubic bone. So basically, around the umbilicus, 3 centimeters above, 3 centimeters below, xiphisternum, 3 centimeters below, pubic bone, 3 centimeters above, 3 centimeters above. So you got M1, a large M2, slightly smaller M3, a large M4, and a small M5. So subxiphoidal, epigastric hernia, umbilical, infraumbilical, and supraumbilical. See, so this is basically the definition that we're talking about paraumbilical. Epigastric is basically one which is 3 centimeters beyond the umbilicus. It can also be taken from this, the definition you can take from this. So all incisional hernias between the lateral margins of both the rectus muscle and from xiphisternum to the supraumbilical area are medial hernias. Point number one. The definition of width is that if you've got multiple hernias, the lateral most should be measured. So see this lateral most here, lateral most here. So that is the width, not the width of this, not this. It has to be combined with. And the length also has to be combined from here to here. It's not length of this. Why? Because the mesh has to be here. You can't put meshes covering this separately. You can't do that. So it has to be a large mesh. So that is why the width measurement and length measurement has to be as shown in this figure. And then of course the lateral. And the provision of lateral is different. Why? Because you can well imagine laparoscopically, you see less and less patients being operated laparoscopically, lateral hernia. Why? Because fixing the mesh becomes a problem in these areas. So you have to quantify or you have to decide which is really lateral. So what is basically a lateral area? Lateral area is basically, it is starting from the lateral margin of the rectus sheath, covering up to the anti-axillary line and beyond the anti-axillary line posteriorly up to the spine. Okay, so in between these two, you got L1, L2, and L3. So L1 is basically medially M1, M2 representing this particular area. Just to remember it. What is M1, M2? Adjacent to it is L1, M3, L2, M4, M5, cell 3. Right? So basically, this is L2, L1, L2, L3, and L4, which is lying more lateral to it. So that is basically once you do a classification like this, then you why? Why is it going to help you? It helps in applying the technical details. I just not told you. Lateral hernias more easily done by open procedure rather than laparoscopically. Why? Because laparoscopic fixation becomes problematic. And if fixation is problematic, then what happens in these patients is recurrence will be much more common. So the decision whether it's open or lap, number one. Number two, how do you fix it? Like for example, let's say the patient has got a hernia which is in the region of the xiphoid. Say the hernia is here. You put a mesh from here to here, you're going to fix the mesh. The ribs are here. The moment you put in a tacker out here, you're going to puncture what? The pleural cavity. What's going to happen? Pneumothorax. So the fixation becomes problem. Here, what's the problem? The whole of the pubic bone. So how do you fix it? Can you apply suture? You can't. You have to tack it. So these are the technical problems. So based on this, you can easily identify what are the problems you're going to face in your surgery. It also helps to decide about restoring the anatomy and the mesh size. Can you restore the anatomy or not? And what mesh size you're going to use? The width of the particular hernia defect gives you prognostic relevance by identifying what? By identifying patients at risk of complications. The larger the width, the more the complications. Why? Because the larger the mesh. The larger the complications. Similarly, the recurrence rate for a hernia would be dependent upon what? Not only the defect, but also on the length. So the length and breadth both are important. And that's why in the first figure, see, it has got a length and width. So all these things have to be taken into account because each one of them is important as far as the ultimate decision making is concerned and decision making is concerned. So see, this is level 2B. Level 2B recommendation. I'll just tell you what the recommendation all about. I think I had a slide somewhere. Where did the slide go? I just come to the recommendation. See, these are recommendations. Remember, must, should, can, and no recommendation. Just remember these. A standard surgeon must do it. Surgeon should do it. Should basically means he should do it. He may not be doing it. Can do it if he wants. Option is there. No recommendation. Do whatever you want. This procedure cannot be recommended at all. Because no recommendation. So these are basically A, B, C, and D. And when we talk about the recommendation A and B are recommendation which should be followed. C and D is up to you whether you want to follow it or not. And that's why the recommendation I was mentioning at that point of time. Right. So this is basically need for classification level 2B. That basically is one which should be done. It should be done, right? Not must, it should be done. So let's see what the abdominal functions are compromised. Why? Because the function are compromised. And that is the main reason. About, I think, 5 or 6 years back, there was not much impetus of going in and restoring the anatomy. Nobody was doing it. Or other people were doing it, but most of them were condemning it. Why do you need to close the defect? Don't close the defect. Why do you need to close the defect? Don't close the defect. A lot of, most of these workshops, you had people, prominent people saying that defect closure is not required. I don't do it, so it's not required. But remember, the abdominal wall has got a function. And these functions were later on recognized. They already had it. We didn't understand them initially. They always had it. The function was always there. We never understood those functions. But now we understand these functions. Number one, the respiratory function of the abdominal wall. Both the internal oblique, the external oblique, and of course the transverse abdominis leads to paradoxical abdominal wall movement. It leads to a problem with respiration. The trunk motion abnormalities. The lordosis that creeps in these patients. Why? Because the balance between the paraspinal muscles and the anterior muscle is not there. Doesn't exist anymore. The larger the hernia, the more the defect. And the more the significant lordosis. And these patients always have a disabling back pain. And compromise of all expulsive functions. Like coughing, sneezing, micturition, defecation. The moment the patient coughs, the abdominal wall should tense. Now what's happening? Can't tense. Everything comes through the sac. So that pressure is now being accommodated where? Through the sac. It should have been accommodated where? Through the wall. Right? So these are all problems which now we understand. And because now we understand, basically we say that these are the problems for which the restoration of the abdominal wall or restoration of the anatomy should be done. Right? So what are the goals of management? The goals of management, number one, is prevent visceral eventration by re-establishing the abdominal domain. See, this is a very good figure. This is a sac and this is the volume. Right? Now, 25% of volume of the cavity is lying out here. Then it is known as loss of abdominal domain. Now, question would be, how do you calculate the volume? Very easily done by a CT. A CT can easily calculate the volume of the sac for you and calculate the volume of the abdominal cavity. If you have the volume of both of them, then you can easily say if there has been loss of 25% of volume or the volume of the sac is more than 25% of the abdominal cavity. That is the loss of domain. If there is loss of domain, try to re-establish it. Number one. And how do you re-establish it? The closure of the defect should be utilizing the remaining abdominal wall. Why? Because that is a dynamic muscular support. That wall is still functioning. Although it's not functioning in the normal way. Why? Because lost the most important attachment of the linea alba. That has to be reconstituted. Until then, the wall is no longer dynamically, muscularly active. And that should all be done in a tension-free manner. That is the whole aim of the surgery. Initially, what was the aim of the surgery? What were we doing? We were doing what? We never bothered about the defect. We just stuck something up there. Just stuck something up there. Now, what happens to the defect side? The defect is the muscle functioning in that particular defect area? No, it's not. And even because of that, the rest of the muscle is also not functioning in the required way. It's functioning, not in the required way. So basically what is happening is that until you re-establish the anatomy to the normal or near normal, your dynamic muscular support, the function of the abdominal wall would not be there as required. In the physiological manner, it should be doing so, right? So that is very important. That's very important. You should do it, right? Okay. So remember, all said and done. Now I'm sure that I've done everything. Now I go ahead and do a surgery. Don't be so fast. Don't be so fast. Why? Because the abdominal wall hernia is a plastic reconstructive procedure. The size of the defect, the adhesions that we are encountering, your competence, the operating time that you will be subjected to, the patient subjected to, and of course the cost of materials. All are basically variables we should be weighing heavily on you. They are things that have to be kept in mind. They are very complex features. The size of the defect, say it is 5 to 10, or let's say 10 centimeters across. You think it's very easy to close that defect? Is it very easy, or does it make sense to keep that 10 centimeters wide and just take a very last, say 30 by 30 centimeters mesh behind, underneath it? Does it make sense? It doesn't make sense at all. That whole gap is there. You have to close that gap. You should close that gap. So that size of defect is problematic. How do you close it? That's problematic. Or even you're doing an open surgery. I can't do laparoscopy. I don't know how to do laparoscopy. I have to do an open surgery. I have to close the defect. How do I do it? That is a major problem. And the moment I enter the abdomen, what do I find? I find a lot of adhesions. So half my time is gone in separating the adhesions. 40-45 minutes, 1 hour, 1.5 hours down the line, adhesions have been separated. Now I see there's not enough time. The anesthetist is at you. Look, this patient already under anesthesia 1.5 hours. And now you want to do another procedure. You have to do the push and everything, and you have to mobilize everything. It takes further 1.5 to 2 hours. So in patients, this surgery may take almost 4 to 5 hours, even 6 hours. Remember that. So the time is very important because the adhesions may be problematic. And for that, you have to competent enough to do all these 3 stages. For doing adhesion lysis, for doing closing the abdomen or rather restoring the normalcy of the abdominal cavity. You have to do that. And then, of course, the cost of materials involved. The amount of mesh that you have put in. If you're doing it laparoscopically, the number of tags that you have to put in. 30 tags, minimum 18,000 rupees. And seeing patients being served to 60 tags. A large defect, 60 tags, 36,000. How many can afford it? So the cost factor is very important, right? The mesh by itself can cost anywhere from 30,000 to 1 lakh rupees. So everything boils down to getting a incisional hernia repair, and the patient is given a bill of, let's say, about 2 to 3 lakhs. And he's flabbergasted. So remember, all these things are important, have to be discussed with the patient. These are very important things to be discussed with the patient. If you do that, you are basically not following the surgical rule. So just come back to that: must, should, can, and no recommendation. Remember that: must, should, can. Remember all of that, right? So should you operate on every patient? No, don't do that. Watchful waiting could be a method, especially those patients where the patient has got a severe cardiac problem, or the patient be having a pre-existing COPD. Even if the surgery is indicated, this patient having comorbid condition. So medical optimization should be done in these patients before you go ahead and do a surgery in a patient's illness. So that is basically the time when you should wait, right? Then comes the important thing, and that is surgery, open or lap, right? Now every symptomatic hernia should be treated surgically. We know that. Open or lap. But even otherwise, if a distal hernia is there, it should be operated. Why? With passive time, this hernia size is going to increase with the passive time, right? Now, one thing we know that there are indications and contraindications. Everything is so hunky-dory with laparoscopy. Everyone wants to do everything, or everybody wants to get it done with a laparoscope. He wants to get it done with a Durbi, right? And you are very happy. You've just learned the technique of doing a laparoscopic surgery, and you say, yes, I'll do it, no problem. You didn't worry about the width of the defect, and you go inside. Now you see that the defect is almost 10 to 15 centimeters inside, and now you don't know what to do. You basically told the patient that I will do it laparoscopically. 15 centimeter defect, 10 centimeter defect. The problem with even advanced laparoscopic surgeons is there. So as a general laparoscopist, you can't do it. So remember, a relative contraindication is basically 10 to 15 centimeters. Some people say 10, some say 15, but 10 I think is a safe level. So anything more than 10 centimeters, be very, very careful. And that is where the classification is very important. The classification of width is very important, which we never do, but it should always be done. Remember that. And this is all grade B recommendation. See, this is good recommendation. These all recommended that they should be done, right? So every patient cannot be done laparoscopically. Okay. So what are the contraindications? I just now told you. Transverse weight more than 10 to 12. Medically unstable. Despite the fact you waited, this patient got severe comorbidities, cardiac, lung, whatever, right? So these patients always safer to go in for a open surgery. Strangulated with gangrene. With gangrene, you know, in these patients, what's going to happen? There has to be a leakage. The chances of leakage is always there. So contamination has to be there. So in these patients, doing it laparoscopically, again problematic. Uncontrolled coagulopathy. A hostile abdomen. What's a hostile abdomen? Hostile abdomen basically is abdomen where entry is fraught with danger and adhesiolysis is fraught with danger. Entering the abdomen is a major problem and subsequently trying to separate the adhesions is a further problem. So these are hostile abdomens. Like for example, a multiple times operated abdomen or for example a tubercular abdomen. These are abdomen really hostile, right? So entry problematic, subsequent dissection problematic. These are hostile abdomens, whatever the cause is. Relative contraindications are technical difficulty that you're going to have. A very heavily obese abdomen. A bowel distension, severe bowel distension, pregnancy, ascites in a patient. Don't do it. Don't operate on any hernia with ascites. Loss of abdomen domain. We already talked about that. If the patient has got loss of abdomen domain, it's always better to do an open surgery rather than a laparoscopic surgery. Or the patient has been damage control surgery, he's got graft all over his abdominal skin. So abdominal skin grafts. Or the patient has got a colostomy site or an enterostomy site. Don't go ahead and do it laparoscopically. Previously, prosthetic meniscus site infected, you have to remove it. Do an open procedure. Incarcerated hernia, infected or contaminated fields. So these are basically relative contraindications. But then these are weak recommendations. Okay. Now surgical principles. Number one, open or lap, decide. Entry is problematic. You have to go in. What is the entry point? Remember one thing, wherever suspecting adhesions, the best point to enter the abdomen is the Palmer's point if you're doing it laparoscopically. The Palmer's point we all know is basically the left subcostal and the mid-clavicular line, right? So that is basically Palmer's point, left subcostal mid-clavicular line. Now this is an area where always the adhesions have to be minimum adhesions. So try to enter through that area. If you're doing an open surgery, then obviously the incision line has to be taken out, and of course the scar has to be taken out. And remember, either go 1 inch above or below the scar into normal tissue, and always enter the abdomen through the normal tissue. Never forget that. That's also true for any kind of preoperative surgery in the abdomen. Always go beyond the scar, either above or below into normal tissue, and always open the fascia in that normal tissue so that they can easily enter the pristine abdomen, and from there put a finger inside and then try to see what is adhering to the underlying scar. Okay, so that's one. Number two, adhesiolysis should be done, but remember, without energy source. Without energy source. Don't use electrocautery, don't use a harmonic, don't use vessel sealant. Don't do it. The moment you do it, you always will be having either immediate enterotomy or a delayed enterotomy, which is much more dangerous. Why? Well, that's going to occur 72 hours down the line. You've done everything, send the patient to the ward, and 3 days later, now the patient has sudden pain in the abdomen. He's guarding, he's got all features of peritonitis. Now what happens? What has happened? 72 hours, the necrosis which was there, which is occurring, now has burst up. So remember, any kind of injury, which is non-obvious injury to the energy source, always manifests 72 hours down the line. So remember, without energy source, it should be sharp dissection. Number one. Number two, the dissection should be such that it includes a part of the parietal peritoneum along with the bowel. So that means dissection toward the parietal peritoneum, not towards the bowel. Remember that. Two principles. Number one, without energy source, and if possible, towards the parietal peritoneum rather than toward the bowel. If open, a tensionless closure or defect should be done either by primary repair or by mobilization with a component separation technique, either simple posterior component separation or with or without TAR, or an endoscopic anterior component separation technique with or without perforative sparing. Now, I already talked about the component separation, I think, in the earlier lectures, so I'm not going to repeat what is there, just I'll be touching on that in one of the future slides, right? If you're doing a plasty whether it's open or laparoscopic, adequate size mesh reinforcement for defects more than 1 centimeter. That's very important, right? So if you got more than 1 centimeter defect, you have to measure the length and you have to measure the breadth. So once you do the measurement of length and breadth, only then you decide on the mesh size. Proper selection and application of features like fixation or mesh. No drains, prevent infection and other complications. So take proper steps to prevent those. Restoration of normal anatomy, what we're talking about, closure of the defect. Grade B, it should be attempted. Grade B, attempted. So you should do it. Reconstruction of linea alba, right? In case of too high tension while reconstructing linea alba, if you do an additional component separation technique, that may be necessary. And that's grade C recommendation. I'm sorry. That's grade C recommendation. Grade D recommendation that you should do other tension defect closure aids. And these are facilitating maneuvers which are basically non-surgical. Like example, see temporary chemical components. Like example, relaxant injection of botulinum toxin A. Used for wrinkles. Pre-operative progressive pneumoperitoneum. Progressive basically what? It means you inflate the peritoneum with, let's say, 10 millimeters today, then 12 millimeters, 14 millimeters, 16 millimeters of carbon dioxide pressure. So basically what you're doing is you're increasing the pneumoperitoneum. That is progressive. Then intramuscular expanders. So these are some methods by which you can hope to increase. But these are all grade D. That basically means no recommendation. Want, do it, don't want, do it. We are not recommending anything. Right? Grade C basically means what? Some recommended, but you can do it. But if you want, that's grade D. Right. So now basically the additional procedure we're talking about, I just told you component separation technique, but just one thing I would like to tell you is that these component separation techniques will give you either 5 centimeters, 10 in the umbilical region, and 3 in the suprapubic region. Why? Because suprapubic, remember the two recti all is stitched like this. The more you try to mobilize them, you'll not be able to mobilize them too much. So the recti coming like this. So the maximum mobilization is in the umbilicus, less in the epigastrium, and least in the pubic. So any kind of CST would give rise to this increase in length. A Fabian, which also cuts the internal oblique, was said to give rise to this kind, which is almost 1.5 times more. 1.5 times more to what Ramirez says. But these are not done anymore. The best procedure now being done is anterior component separation, which is a perforator sparing, or a posterior component separation with or without tar, the two CSTs which are in vogue and which are advised as of today. In those cases where there is a very large defect, even a CST you believe that it will not be able to bridge the defect, there you can take a help of a flap reconstruction, the compound flaps, which will be muscular mucocutaneous flaps, and here you basically have what? The thoracic epigastric flap, or the upper third, middle third, or the superior circumflex artery, or lumbar perforator based iliolumbar flap, or lower abdomen groin flap, or a superior superficial inferior epigastric, or a deep inferior epigastric flaps, right? So these are the flaps which can be used. These are basically what? These are basically myocutaneous flaps, and with these myocutaneous flaps, you can hope to bridge these defects, or you can use tissue expander, right? The question prime is to mesh or not to mesh. That is the most important side. And one thing is very important, anything more than 1 centimeter, mesh. Anything more than 1 centimeter, mesh. Always do the mesh, right? So 1 square centimeters, mesh has to be given, right? Even for small midline hernia, where it's epigastric hernia, 1 centimeter divagation recti, it has to be done. And that's why a measurement of the hernia should be done. And it has to be a dynamic measurement. What's a dynamic measurement mean? Basically means that you have to measure it from outside and inside laparoscopically. So when you go on in laparoscopically, put in a scale and do a measurement. You got those special scales used for laparoscopic measurements. So put it inside. So measure the defect from inside and outside. You can arrive at a correct figure as to what is the mesh size required. What mesh do you like to use? A dual, biosynthetic, or synthetic mesh. We'll just talk about both the meshes advised. And we based on the classification, right? We all talked about that. 5 centimeter overlap is the minimum that's advised. And then the placement of mesh is important. We just talk about what the placement of mesh should be. And fixation is also very important. Let's see what this is all about. So mesh size. Now initially it was advised 5 centimeters overlap, right? What the new recommendation says is it should be abandoned. Instead, the mesh area to defect area ratio should be 16:1. In other words, the radius of the mesh used should be at least 4 times the radius of the defect. Imagine, radius basically means what? This The defect is this is the radius, and using at least what? 4 times this, 4 times, right? So 4 times the radius of the defect should be basically the size of the mesh. That should be mesh, or you can have an area to defect area 16:1, right? So the rule of 5 centimeter mesh overlap should be given up. That's one. Number two, I mean that's only advice, but see, look at the recommendation, grade C. So that basically means you may or may not follow it, still stick. So most of the surgeons are still sticking to the 5 centimeter. But what also is important is, as the defect size increases, the size of the mesh overlap should also increase. That has to increase, right? Now, another grade B recommendation for the mesh type. The mesh type should be only meshes approved for implantation if the abdominal cavity should be used. That's strong recommendation, grade B. So this has to be followed. And what do you say? It says only those meshes which have been recommended for use. What does that mean? It basically means for intraperitoneal, that is IPOM, intraperitoneal only mesh. That means you stick it onto the peritoneum. That means all times it is in contact with the bowel. These meshes should be such that it should not stick to the bowel. The bowel should not stick to the mesh. If the bowel is going to stick to the mesh, it's going to lead to a lot of complications, right? So basically what's advised is that those materials which have been approved, and what have been approved? Basically dual meshes have been approved. So dual mesh basically means what? It has 2 layers to it. One which makes it stick to the abdominal wall, and the other which does not allow it to stick to the intestine, right? So they are dual meshes. So these are the ones that are advised. One more thing is that we are still using a lot of simple meshes, and these are polypropylene meshes for intraabdominal use. Now, you may say that you're just now talking about the dual meshes, now you're saying polypropylene. Polypropylene has been made famous for the fact that it always sticks to the underlying bowel. Always sticks to the underlying bowel, right? Now, that is a hypothetical situation. May or may not be true. A lot of reports are there which says that the bowel adhesion with polypropylene is no worse or better than other mesh material. So why blame only polypropylene? And the thing was that with polypropylene, they said that leads to a lot of endocrine fistula formation and leads to a lot of adhesion formation. What was seen was the endocrine fistula which occurred as a long-term complication of insertion was not because of the mesh. In most of these cases, it was basically because of the tacker that you were applying to the. So the more the tackers, the more the chances of having endocrine fistulas. So what is better is, in most of these patients, you should be using what? Sutures to fix the mesh, right? So that is another. We'll talk about that when we talk about the future. Like we'll talk about the latest or the updates in mesh, right? So here mesh insertion. So you've selected the mesh. You have done the mapping of the defect. Now you know which mesh you're going to use. Now you have to do the mesh inside. The problem in a mesh is 15 by 15 centimeter mesh is very easily used to the 10 millimeter port. No problem. The problem comes with larger mesh, like example 30-30. You can put in a 15 millimeter port just to push the mesh inside. Another method often used by a number of surgeons is that because you've done additional lisses, now you've got the gap in front of you and you've got the skin over the gap. So make a small incision in the gap, push the mesh through the skin and put it inside the abdomen and close the gap of the skin. So that's another method of pushing the mesh inside. 15 millimeter port is always there, you can do it. But one thing you have to remember is that the mesh skin contact should be avoided as far as possible. Minimum skin contact with the mesh. Now, the second thing is you put in the mesh and now you have to position it. When you're positioning a mesh, it should be positioned such that the overlap is always there, the required overlap, the 5 centimeter there. Number two, it should not be wrinkled and there should be no folds in the mesh. That's very important. It should not be overstretched. Remember this. It should not be stretched out, but there should be no wrinkle, there should be no folds. Not excessive stretching out, but it should just be spread out, not stretched out, spread out, right? That is very important. It should be just laid flat across without wrinkles or folds, and it should be having a surrounding all around overlap of at least 5 centimeters. We'll stick to that right now, or up to now, or for the present, until we start believing that 16:1 ratio at the later point in time, right? And I said earlier, larger defects, the overlap should be more than 5 centimeters, not only that. So see, this is how you position the mesh. Where you position it? One, it could be positioned where? As a onlay. One which should never ever be done unless and until you have not been able to enter inside the abdomen. You just dissected the sac around the defect and you just push everything back inside. You not enter the peritoneal cavity and you just close the defect with a mesh. That is the only scenario where the abdomen is so hostile that the moment you try to enter the abdomen, the chances of having endocrine fistula would have been very much there. So you never did. So only mesh over the external oblique aponeurosis should never be done. Why? Because the chance of infection is very high. What is separating from the outside? The skin and the subcutaneous fascia. That's all. Fascia of Camper and fascia of Scarpa. That's all. So the chance of infection is very much there. Number two, the Pascal's law doesn't allow you or does not suggest that this is the place where mesh should be pushed. I'll just show you another future figure, right? The second is a superficial inlay. That means you just put the mesh underneath the external oblique, in front of the rectus abdominis. This is an area which can only possible in open repair. The first one is also only possible, but this is also possible in lap repair. This is also possible in lap repair. How? That you can do a tunneling, subcutaneous tunneling, and you can repair. I've seen the papers there. What do is that it is the abdomen. The whole thing is the abdomen. So you have basically an opening far off, and from there you tunnel up to this area, whole area, apply sutures here, and lay a mesh down through the tunnel, and you go out. Just like you do a tunneling inside the abdomen. So this can be done as a lap procedure also, but by and large it's an open procedure. But this always has to be an open procedure, and this is basically a superficial inlay. You're inlaying under the rectus abdominis sheath. Okay. But now we come to the more important, that's the underlay. One underlay basically it could be in front of the posterior rectus sheath. See the posterior of the rectus sheath. So you can position the mesh here. That's one underlay. The second underlay could be you can position it under the peritoneum or pre-peritoneum. And the third and the fourth is basically the IPOM. I'll just show you the IPOM. So remember, underlay could be two. Underlay to the rectus abdomen, that means in front of the rectus sheath, posterior layer, or it could be underlay which is in front of the peritoneum and in between the peritoneum and the posterior. So it could be here or it could be as shown here. So this is basically posterior sheath. This is basically the peritoneum. So either here or here, both of them are underlay, right? And if you put it here, it is basically the IPOM. This is basically IPOM, or if you want, you can also put in a pre-peritoneal. I just told you, right? So this is basically the IPOM. Now, Pascal's law basically tells you what? That when you have a increased abdominal pressure, is going to be equally transmitted throughout the wall of the abdomen. It's going to push against the wall. Right? Now, when it's going to push against the wall, something which is lying just inside the wall is going to be further stuck to the wall. So, based on this, where would the mesh be put, or where should the mesh be put? Obviously, if the force is working from here, we're working here. If the mesh is here, here, or here, the best places. Suppose the mesh is here and here. What's going to happen? The force is going to push the mesh across here and would be in more conformity with the skin. That is, the chance of dislodgement of mesh applied here and here, superficial inlay, are more based on the Pascal's law with each contraction of the abdominal wall muscle or each rise in the intra-abdominal pressure. That is the problem. And that is why these three places are the best. You can have an IPOM, you can have a pre-peritoneal, or you can have sublay in front of the posterior rectus sheath. Right? So these are the preferred sites. The best fixation, I've just shown you some of the clips that we use. Basically, this is the most commonly right now. This is the most common tack to be used. I think almost 80-90% of tackles being used all over the world are basically pro tack. This is a non-absorbable, but you got a whole lot of methods of mesh fixation. You can use these staples, you can use tacks, you can even use a laser-assisted tissue welding. You can do a fibrin sealant. Just stick amount of fibrin, the mesh sticks to it, right? Or you can use a fibrin glue. Basically a curing. This is the curing you're talking about. Or you can anchor sutures, but the best I think about all these, you can use sutures which can be intracorporeal sutures, or you can use a transfacial suture. Now, when you use a transfacial suture, this is basically just to tell you something. This is a skew strap ethicon which is now being used further, but the problem with this is it's absorbable, it's very costly. There are people using it, but these are the most common. I told you these are the most common tackers that are being used. So these are just figures of some of the fixation methods. The method of applying the fixators or the tackers is a double crown technique. See, one crown here and one crown here. Now basically the second crown is that this tacker is lying in between these two. This is lying in between these two. So basically this is what we show. This is how the tacks are applied. So one layer outside, one layer inside. That double crown technique. But let me tell you, double crown technique application of tacker is very, very costly. Why? The number of tacks that you apply in this patient would be quite numerous, and tacks have their own problem. The problem with the tacks is the tacks, when you see the tack is basically entering into your abdomen, the abdominal wall as an eye form by only 1 to 2 millimeters. The whole thing is what? The whole thing is 2 to 3 millimeters. And the part which is going inside your wall is only 1 to 1.5 millimeters. 1 to 1.5 millimeters. That is what is fixing. Now imagine a patient with a huge amount of preperitoneal fat. This tack should be anchoring where? Into the muscle. Now that fat is so thick that the tack cannot enter into the, or is not able to reach the muscle. So where is the tack lying now? Into the preperitoneal fascia or the fat. Is it going to fix the mesh for long? No. The whole mesh is going to drop off. Suppose if this tack was applied and the end of the tack is in the muscle. Very good. This keep on sticking. But if it's only in the preperitoneal fascia, what's going to happen? By the weight of the mesh and the weight of the tacks, the whole thing is going to fall into the abdomen. So remember, the tacks have to be applied very carefully, seeing the thickness of the abdominal wall, seeing the thickness of the preperitoneal fat. That is very important, right? That's very, very important. So always look at that. So these tacks when applied, and that is why, what is better? Apply sutures along with tacks. At least what's going to happen is the suture is going to keep the mesh in place. It's not allowing it to fall down. It will not allow it to fall down. And we're applying these sutures, basically when applying sutures, there are two methods. You can do intracorporeal suturing. That means the whole of the needle holder, the laparoscopic needle holder inside, and you keep on suturing like this. Right? Stitch from here, keep on suturing all around. That is intracorporeal suturing. The other could be that from the externally. Suppose if this is the skin, you drag a suture from here, bring it here, take it down and take it back outside. And you tie it outside. So this is basically what? The abdominal walls, the suture is coming through the abdominal walls. That's why it's known as the transfacial ligation. The transfacial ligation, when you tie this knot has to come underneath the skin. That's very important. So in transfacial suturing, the number of sutures, the interrupted suturing, you apply as many sutures that you want, and all the knots have to be buried into the subcutaneous tissue. That's transfacial. Easy to apply, everyone can do it. Intracorporeal suturing is slightly more tedious, everybody can't do it. Advanced suturing is required if at all you want to go ahead and do a intracorporeal suturing. So two methods of doing it, right? So what has been advised is what should be done. It should always be a suture fixation alone or in combination with tack. It's never tacker alone. Remember that. If at all you are asked about the best position of fixing a fixing method of for a mesh, it should be a combination of suture fixation with double crown technique of tacker application, or else only suture fixation. But a combination is always better, and that is what grade A recommendation. See, grade A recommendation, best, right? That is basically that you should do it, right? So this is basically, rather you must do it. So this is basically the combination that's only advised. The tacker, I told you, you have two types, absorbable, non-absorbable. What has been advised was, or what was suggested was that tackers for a long time will give rise to pain. So they said absorbable tackers, because they disappear with time, should be better. Now, what has been said is that if it is absorbable or non-absorbable, it does not make any difference as far as the postoperative pain and quality of life. QOL is quality of life is concerned. That means postoperative pain and quality of life is not affected whether you use a non-absorbable or absorbable. Both of them are equal. What can be done if you want to prevent postoperative pain is you can give a regional block injection with local anesthetic just before you extubate the patient. Just before you finish the operation, give a regional block. What about subxiphoid hernia? Remember I told you about the costal margin. That is a real problem. You can apply tack to the lowermost costal margin. That there is no pleura underlying out there. That means the lowermost ribs, which makes a costal margin, you can apply the tackers. But what about above that? Above that, even suturing, the transfacial sutures are problematic. Because the moment you put transfacial suture, you're going to go through what? You're going to go through the peritoneum, the pleural cavity. That means pneumoperitoneum. So what is advice is that above the costal margin, if at all you want, number one, you can apply glue. Number two, you can do an intracorporal suture. And that also very carefully, just sticking it to the peritoneum, not deep stitches. That's very important. That's one of the major problems. And that is why these are areas which are better tackled by open surgery rather than a laparoscopic surgery. Above the costal margin, glue can be used. Non-absorbable tack fixation should be preferred to absorbable. Why? I just now said non-absorbable may be probably better. They disappear. It stands to logic. But the problem is they are very costly. So in terms of cost, non-absorbable tack fixation should be used rather than having an absorbable tack. What about biosynthetic meshes? Biosynthetic meshes, managing contaminated ventral hernia repair is a major problem, and there's still questionable methods how you do it, how you don't do it, whether you should put in a mesh, you don't put in a mesh. That's questionable. I think as far as you all are concerned, just remember that if it is a contaminated field, better not to use a mesh. If you want to use a biological biosynthetic meshes, see, controlled trials. Still recommended, grade B recommendation. Should not be made a mandatory that yes, you can go ahead and use it. There's no problem. Not that. There could be problem. So if at all you want to use a biological mesh, but biosynthetic meshes are one which are now coming into play more and more. They are one meshes which can be used, but remember, if you got a patient with a contaminated ventral hernia or a contaminated field, meshes should be used with very care, great care. Don't do that. Just complication. Then I think we'll finish for today. Just complications, perioperative bleed. No need to go into details of that. Basically, in the region that you're operating, if there's a bleeding, you have to tackle the bleeding accordingly. But enterotomy is one which could be at the time when you're dissecting. I told you, dissect toward the peritoneum, never toward the bowel. When you want to separate the bowel from the peritoneum, cut a piece of the parallel peritoneum along with the bowel. No problem. Peritoneum regrows within what time? 48 hours. We all know that. Reperitalization. So no problem. So always dissect towards the peritoneum. No energy source. Sharp dissection. Delayed, you have used the energy source. At that time, you're very happy. Nothing has happened. I've used the energy source. 72 hours down the line, this patient develops peritonitis. I told you why. Post-operative seroma formation, almost universal, 50 to 100% incidence. I'll just tell you what you do. Infection, chronic pain, and recurrence, right? Just let's run rapidly through them. So, enterotomies, 12.8% to more, both in open and laparoscopy. And I told you why. Energy source, blood dissection. And this we all talked about that. Higher with laparoscopy, we talked about that. Injury to the small bowel is more than large bowel. Why? Because the large bowel sticks much less, and even if the large bowel is sticking to a particular area, that particular area is not much. You don't need to do too much adductus at that point in time. Why? Because it does not cause obstruction. So if at all possible, just do away with that. Don't go ahead and do adductus in large bowel. Now, it can occur as a primary injury. I just now told you as a delayed injury, 72 hours. But this is one injury, late injury, which I was referring to. We're talking about the proline meshes. And they said the mesh causes injury. Probably not. It is attack induced, or it could be mesh. If it's mesh, any mesh can do it. PTFE mesh can give rise to fistula. Proline mesh can give rise to fistulas. Even dual meshes give rise to fistula. What has been shown by dual meshes is that even a dual meshes, the dissolution of the layer which is in opposition to the bowel, which is preventing adhesion of the bowel, dissolutes so early. So early. It has got a variable time dissolution, variable time. So the bowel goes and sticks now to the area which is still lying in contact, and that is an area to which the bowel can stay. That means the layer which was supposed to be there, preventing the adhesion, has gone. So what is remaining behind? The layer to which adhesion can easily occur. So even the dual meshes do not tackle this problem. So it could be tack induced, it could be mesh induced. So it's not only polypropylene. Okay. So primary, delayed, and late injury. What happens if you have enterotomy? You find them at surgery. You've done an open. You find that you've injured the bowel. No problem. Repair it. Open. Everything is open. You can do it. Every surgeon can repair a bowel after you are supposed to do a bowel surgery. So do it. If there's not too much spillage, repair, wash, and insert the mesh in the post rectus. In the post rectus plane. That means sublay anterior to the posterior rectus sheath, or a pre-peritoneal mesh placement. Do that. But if there has been spillage, in that case, just repair the enterotomy and do a non-mesh repair. Don't put in a mesh at that time. And go ahead and do a mesh repair at a later point of time, which is the second option, which is probably a better option. So if you find too much contamination, you expect the mesh to be infected later on, don't do it. Do a delayed hernia repair. Okay. Now, what about entrotomy in a laparoscopic entry? If you have done an accidental laparotomy at that point of time, you find it, do an entrotomy repair, and similar to the open, go ahead and do a mesh repair. So with or without permanent mesh repair, that will depend on you. You have done, you find there's a small opening, no spillage was there, you just repaired it, go ahead and put in a mesh, no problem. That is grade B recommendation. Everybody says that. But the second option could be there that is still very queasy about it, that look, I damaged the bowel, even there was no spillage, there could be infection, so don't do it. What you can do is send the patient back to the ward, and before the discharges occur within 7 to 10 days, now go ahead and do a repair. That means at the same admission, waiting for 3-4 days for the bowel to for the peritoneal cavity to settle down, you go ahead and do a repair. So at the same time, or you can do is you can call this patient at a later point of time. So one option, if you've done an enterotomy, either close at the closure you have to do, either repair at the same sitting, or repair before the first discharge, or repair as a delayed, calling the patient back. Right? So this will all depend upon what? It will depend upon the degree of spillage and of course the proficiency of the surgeon, whether he is able to do a laparoscopic repair of the bowel. But the pragmatic approach, as I told you, is basically is that you are not able to do a bowel repair, so you convert to open. Do an open surgery. Convert, make an incision, do an open surgery, close the bowel and do a primary repair. Or else what you can do is that you're not able to do a repair laparoscopically. Now what you can do is that let the laparoscopy inside, and based on the laparoscopic vision, create a small incision laterally. Right? Drag the bowel out through that incision, repair it and push it back. No problem. This is basically a hybrid. What hybrid? You again proceed with laparoscopy. If you've done a laparoscopy, you injured a bowel, you catch hold of the bowel with a laparoscopic grasper, atraumatic grasper, and make an incision over a particular area to which the bowel can be dragged. Make an open incision 1 inch or 2 inches, put in a Babcock, catch that bowel, drag it out, repair it, push it back, close that incision, and now proceed with laparoscopy. So it's a hybrid procedure. You've damaged the bowel, you repair it outside, you put it inside, and then you close the incision, and then you put in the mesh laparoscopy. Right? So that is basically what should be done. If possible, what you can do should be done. What you can do, right? Lab repair with mesh hernioplasty, that we all talked about, right? Now, what about the undercranial enterotomy? Late presentation, 72 hours down the line. You have to take the patient back. You have to do a re-laparoscopy. You have to do it. Do a re-laparoscopy. Once you do re-explore, then go ahead and decide whether you want to go and you convert to open or you do a laparoscopy approach. You have to repair the bowel. That has to be done. You have to resect or repair whatever is required at that point. If you want to resect, you have to resect, you have to resect. And if you have to create a stoma, do it, depending upon the degree of injury to the bowel. Suppose you damage the mesentery, a lot of gangrene inside, then you have to create a stoma. So whatever is required to manage the bowel, you have to do it. And once you do it, then of course you have to do whatever is required. Now what is required? If you had put in a mesh, and now there has been a leakage of 72 hours, that mesh has to be removed. You can't leave that mesh inside, saying that, look, this mesh will sustain. No, when 72 hours, the soiling of the peritoneal cavity has been so much that the mesh cannot be left inside. At that point, there are no two views, the mesh has to be explanted. It should be explanted, right? And once you do that and you repair the bowel, then you should do a primary repair of the facial defect, right? You should do a primary repair of the facial defect. Now, laparoscopy, open surgical treatment, that has to be done at a later point of time. At that point, just close it and do a delayed repair at a future point of time. Post-op seromas, I told you, the incidence 3 to 100%, peak presence 7 days. Now, what is important about seroma, just one thing I'd like to mention is that complete resolution should be there within 90 days. So, what is important is that this patient has to be forewarned about it. You have to tell this patient, look, you can have a seroma. Because the problem is that you've done inguinal hernia, say, or ventral hernia, and immediately within a week, patient comes back, look, I again have this swelling at the same place. What have you done? You've cheated me. I've got this swelling. This is a hernia record. You have to tell him this is not a hernia, it's just fluid collected out there, right? So 90 days, up to 9 days, you tell him that within 6 weeks, this should regress. If not, then up to 90 days will regress. Now, it's very difficult to make this patient understand, but you have to tell him that, right? But in the initial stages, never aspirate it. Never aspirate it, right? Does it present with some symptom? Usually not. 35% of the patient will become symptomatic with pain, pressure, or erythema, only 1/3 of the patient. In some cases, chronic seroma develop. That basically means even after 90 days, it does not dissolve. So that means this patient will be having a chronic seroma. What do you do with those? Number one, recommendation B. That means this is basically one that should be adhered to. He should be informed. Always do this. Majority resolute. But if it is there, then you can aspirate, but then the patient has to be informed of the possibility of infection in the mesh because of a seroma aspiration. Because only one aspiration doesn't do. If you want, you have to aspirate, you have to aspirate repeatedly, right? So remember that you can, or you may require, or you may require repeated aspiration in these cases. But if the patient develops a chronic seroma, this has to be excised, right? Mesh infection, we already talked about that when we talked about the first lecture we said was on managing mesh infections. So the infection rate almost 9% with open or with mesh, more with open, less with LVHR. That is grade B, and if it is infected, by and large, it should be removed. That is grade B recommendation. Grade D says that there are a number of studies which say that you can preserve the mesh by a number of methods we already talked about, either with interventional conservative therapy, drainage of the pus, irrigate the particular mesh repeatedly, and then intravenous antibiotics that may salvage the mesh up to 25%. Open to question. You shouldn't believe on that. Just remember that if at all the mesh is infected, remove. Simple. But one thing, removal is not so easy. Just remember that. But you have to remove. Recurrence rate and comparative status, lap versus open, is always 3.1 to 12.1%. Meta-analysis 8 trials. See, this is very important. It shows equal recurrence rates, 3.4 to 3.6. So this was an early study, but 8 trials meta-analysis says that the recurrence is almost equal in laparoscopy and open. So this was one point in favor of laparoscopy goes out of the window. It says it said that laparoscopically the recurrence rate is less. No, it's not less. This, at least this trial says it's not. So what are the causes of recurrences? A number of them. Superficial site infection, exposure of defect. It's not been proper. You've not been able to expose the whole defect, or there has been Swiss cheese defect. The overlap has not been proper. You've not done an overlap in a patient being approached laparoscopically. Or it has been a management of recurrent hernia. They tend to recur again. Morbid obesity. Tags have not been applied, only tags have been applied. You didn't apply any sutures. Difficult locations, like for example the lateral wall, and you still wanted to do laparoscopically. You'll have recurrence. Repeated pregnancy post-repair. You did a repair, and you should always advise that, look, subsequent pregnancies, subsequent seizures, you will have recurrence. That is very important. So post-surgery, repeated pregnancies. Persistent pain, again, important problem. The cause could be the patient is very high sensitive. That's very there. The mesh weight and inflammation is very important. And on that note, you have to remember when we're talking about one of the future lectures, updated meshes, the mesh weight, the amount of mesh that you put inside is very important. And that's why less amount of synthetic mesh should be put in. And that's why now we're talking about lightweight meshes. We're talking about porous meshes. That's why the whole concept of lightweight meshes. So the more the mesh inside, the more the amount of foreign material inside, the more the inflammation, more the pain. Allergy to that material. Perineural inflammation. The transfacial sutures that you applied were very tight. They should be just tight enough. They should not be loose. They not should be tight. So loose or just tight sutures. The tacker was such that it went and impinged onto a nerve ending. So tack induced can lead to a prolonged pain. Transfacial suture, I just talked about that. Entrapment or tissue ischemia. Again, tight sutures. So you have to be very careful about that. So what are the contentious issues right now? Should LVHR be the new gold standard? Should the suturing defect be done? Now we say yes, should be done. What should be the type of mesh? What should be the site of mesh? Site we have decided. What should be the type of mesh? Should be composite, dual, polypropylene, what? Fixation technique, we have decided about that. Tax, absorbable, non-absorbable, that is again questionable. People will say, I'll use absorbable. No difference absorbable, non-absorbable, cost is different. That's there. What about the transfacial suture? Should be absorbable or non-absorbable? One thing very sure that they should be non-absorbable. They should be non-absorbable transfacial suture. Why? A non-absorbable transfacial suture, especially Vicryl or Dexone, would be there at least for 30 days. And 30 days is enough time for the fibrotic process to take place between the mesh and the peritoneal cavity. Enough time. So, absorbable is always better. A non-absorbable will give rise to lifelong, could be a reason for lifelong pain. Why? because the tightness of the suture with a absorbable, suppose even if you apply it tight, it will disappear within 30 days. So the tightness will disappear. So that pain will no longer be there. But if the suture is non-absorbable, it will persist lifelong. Right? Intracorporeal suturing has been such that two types sutures have been done, two deep sutures have been done. It has trapped some nerve ending into it. That again could be a cause. Or whether you should do incorporeal suturing. If you are adept enough, you can do it, but not many people are doing it because this is much easy cuts on the operation time, right? And should you put a mesh in CDC type 1 and CD type 2? We all talked about CDC type 2, which basically means minimal amount of spillage, that means contaminated. Type 1 is what? Clean. Type 2 is clean contaminated. Contaminated and then frankly infected. 1, 2, 3 and 4. So 1 and 2 should you put in a mesh? That is again debatable, but there are features which are saying yes, you should do it. What about obesity and incisional hernias? Grade A recommendation. That means this is laparoscopic approach should be the preferred approach. Why? Because the infection rate in this case is yes, very high. Grade B recommendation, the need for additional technical steps are always there in a severely obese person. The technical details are important. The technicality is difficult. Putting in a mesh is difficult. Fixing the mesh is difficult. Everything is difficult, right? The overlap has to be much more difficult. So ultimately, the recommendation of 2019, 18, and 2018. These are recommendations which are now the latest recommendations, and which says that the LVHR, everybody now says it should be preferred method. No, has slightly lower rate of wound infections, not mesh infection. Remember, wound infections, and should with less amount of bleeding. Only 2, and substantiated by what? 7 meta-analysis and a Cochrane systematic review. I think we'll finish out here. This I think we'll talk about later. Thank you. Any questions right now? I'll just unmute you all. Or you can unmute yourself if you want. If you have any questions, you can ask me. I've unmuted you all. Any questions? Okay, thank you. I think it was a fairly extensive talk today, almost 2 hours. I just wanted to finish this. And next, I think we'll be talking about update on meshes. I think these hernias, which you see on the screen right now, are hernias which are not very common. Read it up yourself. Parastomal hernia is one. I think we can talk about that when we talk about colostomies and colostomies. We can do that with parastomal hernia. That is a part we'll be touching at that. But I think we all talked about hernia. And the rest of them are not very common. You can just go and read it up yourself. I don't want to waste time on that. Okay, so thank you everybody.